Welcome to this week's presentation regarding the physical assessment of the heart and the neck vessels, often referred to as the cardiovascular system. I'd like you to pause the video for a second and take this anatomy challenge. Label the chambers, the valves, and the great vessels. The heart has different layers. First, we'll talk about the pericardium, which is very tough and fibrous. It's a double-walled sac and it surrounds and protects the heart. Within the pericardium, the two layers contain just a few milliliters of serous precardial fluid, and think of it as being a buffer. And this fluid is there to ensure that there's smooth movement and friction-free movement of the muscle, the heart. The pericardium is adherent to the great vessels, the esophagus, the sternum, pleura, and it anchors itself to the diaphragm. The next layer is the myocardium, and this is the muscular wall of the heart. The myocardium is what creates the pumping. The endocardium is a thin layer of endothelial tissues, so endocardium, endothelial, and it lines the inner surface of the heart chambers and its valves. We're going to look a little bit more closely into the cardiovascular blood flow. And we know that from the liver to the right atrium, blood flows unoxygenated through the inferior vena cava, but we also have blood coming from the superior vena cava, draining venous blood from the head and the upper extremities. Now, from this area, the right atrium, the venous blood is going to then move through the tricuspid valve to the right ventricle. From the right ventricle, venous blood flows through to the pulmonic valve to the pulmonary artery. And this is where we are now going to get oxygenated blood. Now, the lungs are going to oxygenate the blood, move it through the pulmonary veins, which now are returning fresh blood with oxygen to the left atrium. From the left atrial area, blood is going to flow through the mitral valve, sometimes referred to as the bicuspid valve, and it's going to end up in the left ventricle. This left ventricle is responsible for ejecting blood through the aortic valve, moving it to the aorta, where now your body can receive oxygenated blood. Remember, once it gets to this, the circulation is just a continuous loop, and the blood is going to keep moving by shifting pressure continually, and it's flowing from areas of high pressure to areas of lower pressure. I have attached a video into this slide, so take some time to watch it. It's a really quick video, and you can watch as blood moves through, and you can click on the slide and test yourself if you have memorized the flow of blood. Now we're moving on to the actual conduction cycle. And the cardiac cycle, it's a very rhythmic movement of blood through the heart. Okay? It's very timed and synchronous. And it has two phases. The first phase is diastole, and the second is systole. When we're in the period of diastole, our ventricles, so those lower chambers, they're going to be relaxed. This relaxation allows the chambers to be filled up with blood. This cycle, this part of the cycle, is actually taking up 2/3 of the overall cardiac cycle, this rest and relaxation to fill up the ventricles. Now then the heart will contract once blood is in the ventricles, and as the contraction is occurring, this is systole. Now during systole, blood is then going to move through the ventricles because your ventricles are pumping. It's filling up the pulmonic and the systemic arteries. Systole only takes about 1/3 of the cardiac cycle. Now in diastole, remember, the ventricles are relaxed. So what this means is that your AV valves, which are the tricuspid and mitral valves, they have to be open to let blood flow through while the ventricles are just there to collect the blood. Now, usually when this is occurring, you shouldn't hear anything. It should be a silent event. Now, the pressure in the atria becomes higher because it's moving on a gradient than that in the ventricles. And that's what's pushing the blood through the AV valves into the ventricles. So blood's pouring out rapidly into those ventricles. And this first passive filling phase, this is called early, or sometimes it's called protodiastolic filling. But towards the end of diastole, this is where your atria are going to contract. And they're pushing just that little last amount of blood. Usually it's about 25% of the blood left into the ventricles. And we call this stroke volume. This active filling is called presystole or atrial systole. Sometimes you might even hear it referred to as the atrial kick, just getting that last a little bit amount because the atria are contracting. When this happens, it causes a small rise in left ventricular pressure. Now, with systole, so much blood has to be pumped into those ventricles that eventually that low pressure system has to increase. And the ventricular pressure is finally high enough, higher than the atria, that now it's going to push it back up. And it's pushing through the mitral and tricuspid valves. But first, those have to swing shut. Now, the closure of the AV valves contribute to the first heart sound. So again, when the AV valves close, the tricuspid and mitral close, this is where you're hearing that first part of the heartbeat. Lub-dub, lub-dub, lub-dub. It's the lub sound that you're hearing. And sometimes this is referred to the S1. So again, when the ventricles get enough ventricular pressure higher than the atria, those valves, the mitral and tricuspid valves, which were once open to collect blood, now they have to be closed because the AV valves need to prevent any regurgitation or backflow of blood back to the atria. For that very brief moment, all four valves are going to be closed. The ventricular wall contracts, and then as this contraction occurs against the closed valves or closed system, we're going to have enough pressure building up that eventually we're going to have the opening of the valves that are going to allow blood to eject into the aorta. Okay, the aortic valve is going to open. Now, after the ventricles expel the blood or contract the blood and eject it, eventually the ventricular pressure is going to fall. And when this pressure falls enough, blood can flow backward into the ventricle. And this causes the aortic valve to swing shut. When you have the closure of these semilunar valves, this is that sound that you're going to hear. It's the second heart sound, or the S2. Lub-dub, lub-dub, lub-dub. It's the dub. So S1 is the lub and S2 is the dub. And when you hear S2 sounds or the dub sound, you know that this ends the systolic cycle. And then we just go back to diastole again, right? All four valves are closed again. The ventricles relax, and then eventually the atrias get filled with blood, and there's enough pressure, and it pushes through the mitral valves and the tricuspid valve that open up again, and we move that blood back into the ventricles. Okay, so again, the mitral and tricuspid valves, these are called the AV valves because they open up from the atrium and the ventricles. Now, there are some things that occur too on the right and the left side. Think about how synchronous everything is. These things are happening at the right time and at the same time because as the events occur together, we can have depolarization of the myocardial. As a result, there's going to be two distinct components of each of the heart sounds. You hear them separately. You're going to hear the mitral component. You're going to hear the tricuspid component in that first heart sound. And the second heart sound, the S2 or the dub, you are going to hear the aortic valve closure and the pulmonic valve closure. Now, looking at this, now that we know the cycle, let's look at the conduction. Now, of all the organs, this organ, the heart, is very unique because it has automaticity, meaning that the heart contracts all by itself. It's very independent of any other signals or regulation from anywhere else from the body. It works on its own. And it contracts in response to any type of electrical current that's conveyed by this system. So, there are special cells in the SA node. The SA node is the sinoatrial node, and you can see it here up in blue. And this node lives near the superior vena cava and initiates the first electrical impulse. Okay, so SA node. And you think S starts with, starts with S. Everything starts with the SA node first, okay? And because the SA node has its own intrinsic rhythm, we usually refer to this as the pacemaker of the heart. Now, once that pacemaker sets off the SA node, it's going to travel down. This conductivity travels down, and it crosses the atria to the AV node. And this is going to be in that atrial septum, right above the ventricles. There's a slight delay, so the atria have time to contract before then the ventricles become stimulated. And the impulse travels through the bundle of His, which you can see here in yellow. The right and left bundle branches then get stimulated as well. And finally, this conductivity moves through the ventricles. Once we get this electrical impulse stimulating the heart, it's going to allow the heart to contract accordingly. And here you can see that the small amount of electricity actually spreading through the body surface can be measured and recorded, right? We call that an electrocardiogram. So this ECG wave that you see correlates with the different activities that are occurring, the different sequence of activities that are occurring in the conduction cycle. So when the SA node fires, this is your P wave. And you can see that the yellow, when the AV node fires, it's your P moving to your Q. And then the Q is where the conductivity is at the Purkinje fibers and getting ready to contract the ventricles. For this lesson, we're not going to go too deep into what's happening at each part of the ECG wave, the P wave, the PR interval. You'll have a separate ECG class going over the different components. The heart is a cone-shaped organ, and we refer to the top of the heart as the base and the bottom of the heart as the apex because the bottom of the heart is pointy or pointier. If you take your right fist and put it over the left area of your precordium, or that anterior chest covering your heart and your great vessels, that's about the size of your heart. And it extends from the second to the fifth intercostal space, just right of the mid-clavicular line. This slide is going to be very helpful as you prepare for your exam. This slide answers many questions that may be asked. So we've established previously that systole is the lub and diastole is the dub. Lub dub, lub dub, lub dub. So when systole occurs, that S1 sound, that first heart sound, the lub, you're going to hear it loudest at the apex. at the most narrow area of the heart. And you can see that here in the image. Once we move to the dub, we're actually starting diastole or rest. And this is where you're going to appreciate the dub sound. So lub dub, lub dub, lub dub. You're going to appreciate the S2 louder at the base or the top of the heart. Now, this doesn't mean that you only hear S2 at the base and S1 at the apex. It just means that the intensity of the sound is louder for S1 at the apex and louder for S2 at the base. Now, you may be asked, well, what causes the lub sound? What causes the dub sound? So here you see again, this is reiterating what was on a previous slide. The lub is caused by the closure of the mitral and the tricuspid valves. Okay, so you get that lub. The dub sound is actually because of the pulmonic valves and the aortic valves closing, making the end of systole and starting diastole. Now, sometimes there's some abnormal sounds, and this is due to the improper closure or could be the improper opening of the valves. And we refer to these extra heart sounds as cardiac murmurs. Now, some people think that if you hear an extra sound, lub dub sh, that it sounds like it's Kentucky in your stethoscope when you're listening. And some people say that this extra heart sound that happens before the S1, so psh, S1, right? Psh, lub dub, that this is actually sounding like Tennessee. Now, I don't really get that from that, but you will see it in many textbooks and hear it in many lectures. I have put different heart sounds here so you can hear the different heart sounds. So I would recommend putting in your earbuds or your headphones and listening to these normal heart sounds. If you want, there is an active link in your PowerPoint that you can go to, and you can hear other heart sounds there. We're moving on to developmental competence and just remembering from physiology that a fetus heart, before the baby is born and disconnected from the mother via the severing of the umbilical cord, they are not using lungs for oxygenation of blood. The lungs are actually a non-functional component during fetal circulation because we have compensation from the placenta where oxygenation takes place. Another thing to realize is that with children, the position of the chest is actually more horizontal in the infant than you would appreciate in an adult. So because of that reason, the apex is actually higher. And instead of being at the fifth intercostal space, it reaches the adult position when the child reaches age 7, more or less. Now let's talk about the differences of the cardiovascular system during pregnancy. It's really amazing how adaptable our cardiovascular system really is. And it's going to ensure that not only are we going to have enough blood for ourselves as a pregnant mother, but we're going to have enough blood supply to the uterus and the placenta. It's very important to deliver oxygen and nutrients to the fetus, and it will allow the mom to function normally during this pregnancy state. Blood volume actually increases by about 30 to 50% during pregnancy, and it can be more or less at different trimesters or different periods of the pregnancy. And with the most rapid expansion actually occurring during the second trimester. During this time, it's creating an increased stroke volume or amount of blood being ejected and amount of cardiac output out into the body system. This will increase your patient's pulse rate about 10 to 20 beats per minute more. The pulse rate will rise during the first semester, and then eventually it's peaking in the third trimester, returns completely to baseline around 10 days postpartum. It's really amazing. And despite the increase in cardiac output, the blood pressure decreases in pregnancy as a result of the peripheral vasodilation occurring. So if you open up all the blood vessels and allow more room, then it doesn't require as high a pressure to circulate the blood. And this is helpful because you have so much blood moving through the body. Remember, 30 to 50% more. Interestingly enough, during the second trimester, the blood drops to the lowest point. And then after that, during the third trimester, it starts to come back up again. Now for our oldies but goodies, the aging adult. We absolutely know and understand, research has shown us, taking care of patients have shown us that there are going to be some hemodynamic changes that occur with aging. We know that we've lived a good life and we've done some things during our lifetime. And so we may have created a circumstance where we develop cardiovascular disease. Maybe we also have some issues with smoking and diet and alcohol use. This also may be due to some exercise patterns of our patients, stress levels, and overall health. We also know that during aging, we are going to see an increase in systolic pressure, but it doesn't necessarily mean that the diastolic pressure is rising. The increase is not because they're getting older, more or less, but it's because the wall itself of that left ventricle, which does most of the pumping, it actually is increasing in thickness. Finally, the diastolic blood pressure really does decrease after the fifth decade or, in your 50s and older. So you're going to see a wider range of systolic blood pressure and diastolic pressure because your systolic is going up and your diastolic is going down. Now, there's no change in the resting heart rate, really, unless there's some pathological change occurring. And cardiac output shouldn't be changed also just due to aging. If you're noticing these things happening with your patient, it's probably because there is a pathological process or disease causing these changes. And then finally, there is a decreased ability of your heart to augment or to make the appropriate changes of cardiac output when you're exercising. So this might leave our patients in states of higher muscle fatigue, increased sense of dyspnea may occur, and will decrease the overall skeletal muscle performance of most patients. And in talking about culture and genetics and how it affects the cardiovascular system, we know that CVD or cardiovascular disease is the most common underlying cause of death in all of the world. About 32% of all global deaths are due to CVD. And 80% of these deaths occur in lower and middle income countries, usually about equal in terms of male patients and female patients. In the US, scary projections are showing us that by 2030, about 44% of all adults will have some form of cardiovascular disease. So we really need to educate all patients about favorable lifestyle changes, no smoking, decreasing their BMI, so no obesity, so BMI is less than 30, increasing physical activity, eating a healthy diet, balance with fruits and nuts, vegetables, whole grains, fish and dairy products, and then having less of the refined grains, processed foods, sugary drinks, and avoiding trans fats and sodium whenever possible. Now, up until the age of 64, men actually have a greater risk for cardiovascular disease than women. But did you know that after that, over 65, women actually show a higher percentage of hypertension than men do. I want to refer you back to the book to look more closely in genetic differences as well as cultural differences that may change and increase the risk of your patients. Now we're finally ready to move on to the actual physical exam. So we're moving on to now, first, the subjective history. Remembering that subjective history is what the patient tells you. So we're going to ask about, first of all, many times patients will come in complaining of chest pain. And when they do, we have to be ready to use our mnemonic old carts to talk about this chest pain. Now, when did the chest pain happen? That's onset. And they might point to their mid chest. That's the location. How long is this chest pain lasting? Well, 2 minutes, about, um, you know, 10 times an hour. Duration. It's very intense. Well, if your pain level was 0 to 10, 0 being no pain and 10 being the worst pain, how intense it is. It may be a 7. What makes it worse? When I try to climb the stairs, aggravating factors. What makes it better? When I rest or lay up in my recliner. Those are relieving factors. Does it radiate anywhere? Yes, it actually, I can feel it a little bit in my jaw and in my shoulder. And how often are you feeling this again? Can you clarify? Yes. It seems like it's coming and going every couple of minutes, about 10 times an hour. And it started this morning. Right? So use your old cart mnemonic to help your patient to explain to you what is going on. Now, cardiac chest pain doesn't always come from cardiac etiologies. You can see with this picture here that there are some other common causes of chest pain that are from the pulmonary system. It could be from the gastrointestinal system, musculoskeletal, and sometimes even emotional things can cause chest pain, like anxiety and depression. Part of the history requires you to ask not only about what's happening now, but their personal and family health history as well. So I'll also extend my questions into social history, understanding what their household is like, their occupation, their marital status, support system. I'm looking at socioeconomic issues. Do they have an ability to purchase foods and medicines appropriately? Is it their employment or maybe nursing school stress affecting their health? I'm asking about their medications. What kinds of medications are you taking? Prescribed from a provider, but also over the counters. What herbal medications are you taking, or holistic medications might you be taking? And not only what has been prescribed to them, but also I'm wondering about the compliance. How often are you taking it? Are you taking it as prescribed? I'm going to ask very directed questions about smoking. If they say yes, I want to know how many packs per day, because eventually I need to know how many pack years this patient has smoked. And you can use this formula to help you figure that out. So for example, 1 pack a day equals a 1 pack a day equals 365 days of smoking, right? So 1 pack a day over a year, that means that they've had 365 packs of cigarettes. And you multiply that by how many cigarettes are in each pack, they're actually smoking 7,305 cigarettes. This is equivalent to a 1 pack year. If they smoke 2 packs a day, then you would double this amount of cigarettes, 14,610, and you would have a 2 pack year history. I'm also looking at diet, trying to get a good sense of what they normally eat over a 24-hour period. I'm looking for information regarding physical activity or inactivity. If there's reason to believe that they have hypertension, hyperlipidemia, which is high cholesterol, diabetes. This all contributes to cardiovascular disease and can be associated with overall obesity. We look at this, and this is called metabolic syndrome. And we have visceral obesity, insulin resistance causing eventually diabetes, hypertension, high triglycerides, and low good cholesterol, HDL. I'm also going to ask them to describe any current health concerns other than their cardiac history, but then I want to get a detailed cardiac history too, as well as a detailed family history. Is there anybody else that's ever had coronary artery disease, mitral valve prolapse, pericarditis? Has anyone had a heart attack or myocardial infarction? So it's okay to ask very directed questions here, very close-ended questions, if you're not able to get the information using an open-ended technique. Now, it's very important also to talk about shortness of breath. This is something that is a common complaint as well. Shortness of breath, or SOB, once they do describe their shortness of breath, you want to know, is it on exertion? Is it when you're trying to do an activity like after walking, after climbing the stairs? Or is it just at rest when you're sitting in front of the TV and watching your favorite show? Now, there's other types of dyspnea that I want you to be aware of, and it may pop up on the test. Paroxysmal nocturnal dyspnea. This is when your patient has been sleeping flat, supine for several hours. And because of this increase of blood flow causing a buildup in their lungs because it's not circulating correctly, you get pulmonary congestion. So what happens is they wake up in the middle of the night, so the word nocturnal, and then dyspnea, they become short of breath. And they need to sit up and gasp for air. And by sitting up, it allows that pulmonary congestion to be slightly relieved. Now, this is different than just orthopnea. Orthopnea is when you just overall, you are very uncomfortable when you're laying down flat. So these people usually, they sleep in their recliners or they use a lot of pillows to prop themselves up. This is orthopnea. Okay, so different than paroxysmal nocturnal dyspnea. This is the patient sleeping for several hours and then being awakened because of the buildup of pulmonary congestion. Again, orthopnea, they're just overall uncomfortable and they don't lay flat. I do also ask about fatigue. Fatigue can result from having a decreased cardiac output. And usually over time, patients that experience fatigue, it gets worse in the evening. So you want to ask your patients to get a good measurement is not only, you feel fatigued now, but how did it feel a month ago? How did it feel 3 months ago, 6 months ago? What about a year? Are you doing things now in a less active form than you were a year ago? Were you more active than you were? Were you more active 6 months ago than you are now? When you get these chief complaints, you can also use the old cart mnemonic to get more answers. Onset, location, duration, etc. Now we're moving on to the hands-on physical exam. How do we prepare ourselves? You want to stand on the person's right side. This is going to help facilitate your hand placement for palpation, but also for auscultation. It also allows you to view the neck veins and auscultate the precordium effectively. You want to make sure that the environment is appropriate. Warm rooms, quiet rooms make the best environments for a cardiac exam. If the patient is shivering, it interferes with the heart sounds because they're moving back and forth. And also, if it's very loud in the room, this ambient noise is going to make it very difficult for you to hear. Even with the best stethoscope, you still prefer a quiet room. So when you're in lab later this week, or perhaps today, you want to make sure that you provide an opportunity for quiet so that everybody can hear the heart sounds. For our patients, you also want to make sure that they are draped appropriately and they're comfortable. Only expose the areas that necessarily need to be exposed. And remember, your stethoscope must always touch your patient's skin because clothing or a gown can create ambient noise from the movement and the rustling of the clothes. Make sure that you use an alcohol wipe to clean the end piece and that you know which side is the diaphragm and which side is the bell. We will inspect, we'll palpate, and we'll auscultate during this examination. And ask yourself, why don't we percuss? So first, ask yourself why we use this technique, percussion, and why we wouldn't do this in the cardiac exam. So overall, I'm inspecting and I'm looking at just the general appearance of our patients. Remember the general survey. I'm looking at the patient's build, their skin color, making sure that it is appropriate to their race and ethnicity. I'm checking the level of consciousness. I'm looking for any obvious signs of shortness of breath, dyspnea on exertion, and their overall affect. Do they look distressed? I'm looking too and considering the lifespan. Are they an oldie but goodie? Are they younger? And any transcultural considerations that might change my patient's care and how I tailor it specifically to them. Now, skin, hair, and nails, we always assess. We always assess skin at every system. And now I'm looking at the color and the temperature of the precordium area. I'm checking for symmetry. I'm looking for cyanosis. I'm looking for clubbing of the nails and making sure that the temperature is warm and dry and even. I'm also going to look at the extremities, although this is also crossing over to the peripheral vascular assessment, which we'll talk about in the next presentation. I'm checking for any vascular changes, capillary refill, and looking for edema. And of course, because this is the heart and neck vessels, we are going to look for neck vein distension of the vasculature. The first thing that you want to do is always inspect, move to palpation, and then auscultation. And here you can see that the examiner is palpating each of the carotid arteries. You can find the carotid artery just medial to the sternomastoid muscle of the neck. Only palpate one carotid artery at a time. Now, usually when we palpate for pulses, we try to do a technique where we're palpating at the same time, right? Because we're trying to check and assess and measure simultaneously. But for the carotid, what would happen if you pressed on both arteries at the same time? You are going to compromise arterial blood to the brain. So definitely only use one, not bilateral. After you have located the pulse and you recognize that the carotid artery actually correlates with your S1, then you're going to take the bell of your stethoscope. And for most of your stethoscopes, it's going to be the smaller end. Some stethoscopes, it is actually, to assess the bell, you're just putting different pressure on one end of the stethoscope. But for most, it's the smaller side. And you're listening over the carotid artery for a bruit. And a bruit is this blowing, swishing sound. Think of something turbulent moving through something very small, creating this sound. This is bad, right? It could mean that there's some type of blockage. Why is there so much turbulence there? Normally, and hopefully today in lab or when you listen to your patients, you don't hear anything. It's normal to not hear a carotid bruit. Now we're going to look at the jugular vein and we're looking for pulse and pressure. And you're going to stand on the right side of the heart. Why? Because the veins have a direct route to the heart from the right side of the patient's jugular area or neck area. So you have to use either the internal or the external jugular vein, or you can use both. The measurements are going to be very similar. How are you going to know it's a vein versus the artery? Arteries pulsate and veins typically do not, right? Because veins are a low pressure system. Now you're going to see the top of the external jugular vein and ask yourself, is it distended? Do you see here the distension? It's filling up. And this distension is going to occur over the sternomastoid muscle. And sometimes you just see it right above that substernal notch. Now, position the patient now, start supine, and then move the patient anywhere between a 30 to 45 degree angle. And use your bed to help you. It usually has a little, I'll call it a compass to help you know what degree you're at, because it really is more exaggerated than you think. You're going to take the pillow out carefully from under the neck because you want to avoid any flexion. And this is going to allow you to see if that distension has resided. So when you have the patient flat, see all the fluid is moving towards the jugular vein, moving and filling. But when you have the patient at a 30 to 45, all that pressure should flow back down to the heart. You see here? This patient, though, that pressure is not flowing back down, which means he has jugular vein distension. So what are you going to do now with the jugular vein distension? You're going to ask your patient to turn their head slightly away towards the left, and you're going to find this cardiac landmark. You're going to look for the sternal notch, the manubrium, and the angle of Louis. You're going to put your straight edge or your ruler up, and you're going to find where the distension goes up to. So let's look at this gentleman here. It actually goes all the way up to the jawline. So if we measure from the jawline and we move across, his distension is actually 6, 7, 8 centimeters, almost 9 centimeters, which is abnormal. Elevated jugular vein pulsation is anything above 3. So we want to be less than 3. Normally, it's going to be at this level. But if it's elevated a little bit, it could be, 2, and that's fine. And this is all measured at a 45-degree angle. What does this mean again? It means that there's fluid congestion, fluid overload. Your heart is not pumping effectively, telling us that there is probably a degree of heart failure. Let's practice. The findings from an assessment of a 75-year-old patient with lower extremity edema include JVP of 5 centimeters above the sternal angle when your patient's at a 45-degree angle. And you know that this indicates what? If you picked elevated pressure related to the heart, related to heart failure, you're correct. Okay? This elevated pressure being more than 3 centimeters is telling you that there may be a degree of heart failure. Now we're going to inspect and we're going to palpate. And we're going to look over the precordium area, again, the area over the heart and the great vessels. And we're just checking. We're making sure that there's no visible pulsations. And those visible pulsations usually occur in the ventricular areas. These are called heaves and lifts. And heaves and lifts are this thrusting force of the ventricle during systole. And when you see it, it can tell you that the heart is working very hard. But this is different than a thrill. A thrill is something that you actually palpate. So what you're going to do is take your hand, your palm, over the different valve areas, and you're going to feel for thrills. Okay, so you feel for thrills, palpate, and you look for heaves and lifts. And you also want to know what area you're looking at. Finally, you're going to look for the PMI, which is at the 5th intercostal space midclavicular line, because this is where the apical pulse is going to be, or impulse is going to be best. And this pulsation is created when the left ventricle rotates against the chest wall, and this happens during systole. So you're going to roll your patient over. If you're not able to appreciate where there's supine, you roll them over. You can see it in this picture and this picture, and you're going to feel. Try to use your fingertips because they are more sensitive, but sometimes having more coverage can help you locate initially where the apical pulse, or the PMI, sometimes called the mitral area, is located. During an assessment of a 68-year-old man with a recent onset of right-sided weakness, the nurse hears a blowing, swishing sound with the bell of the stethoscope over the left carotid area. What does this tell you? You have to think about, going back a few slides here. This is telling you that there is blood flow turbulence. Remember that this is called a bruit. The nurse is examining a patient who is maybe experiencing some possible cardiac enlargement. So what statement is true about percussion of the heart? Remember what I was asking you about percussion. If you look here, you'll notice that actually percussion is not a useful tool. And it's because studies have shown, so the answer here is C, that when you percuss the cardiac borders, even if you are a very skilled provider, it's not going to correlate very well, moderately at best, to what the actual true cardiac borders are. And when we talk about cardiac borders, what I'm saying is the outline of the heart, right? The size of the heart. And then you think about the ribs are in the way. If you have breast tissue, that's going to be in the way. And if the patient's obese, that's also going to be in the way. Think of a very muscular patient. That's also going to be in the way. So it makes percussion very difficult to really understand where the borders are. So instead, thank God for technology. We have chest x-rays and we have cardiac ultrasounds or echocardiograms that give us a more significantly accurate view of the heart. And if we're trying to detect heart enlargement, you would use imaging. So it's time to use our stethoscope, and we're trying to listen for the heart sounds. You're going to use your diaphragm first. You're going to hear a lub-dub, lub-dub, lub-dub at every cardiac area. And remember, lub is the first heart sound, or S1, and dub is the S2, or second. And then finally, you're going to switch over to the bell because the bell is detecting any abnormal heart sounds and murmurs. Okay, so make sure your stethoscope is in correctly. Your earpieces are nice and snug, no leaks. And the earpieces are actually, they're tilted a little bit if you've noticed, and it should point toward to your nose. Think about your ear anatomy, how it would fit best. You're going to place your stethoscope in the aortic area, the pulmonic area, then Erb's point. Erb's point is not a cardiac valve area. Rather, it's the point where we hear S1 and S2 about the same intensity. Again, going back to that slide, remember we hear S2 louder at the base, which is the top. So you're going to hear S2 louder at aortic and pulmonic areas. And then S1, you're going to hear louder at the tricuspid and mitral area because this is the apex. S1, apex. I always think of A1, right? So apex, A for apex, and S1 for the first heart sound. Second heart sound is S2 at the base. Now, it doesn't mean that if you don't put your stethoscope right at the second intercostal space, right of the sternal border, you're going to not hear the aortic area. It just means that this is where aortic sounds are heard best. And when you put your stethoscope there, it's not telling you that that's where the valve is actually. It's telling you that that's the best place to hear that sound because the heart tissue is in the way, you have the sternum in the way, and you also have the ribs, right? Or the costals. So it's projecting best to these areas. The valves are actually right in here, right? It's projecting best to these areas. Really, what you want to think about it is in terms of areas itself. Because if I put my stethoscope right here and I don't hear, I'm just going to adjust, right? I'm just adjusting into that area until I do hear a strong S2 sound and I hear the aortic heart sound. You can use this mnemonic. There's others, but this mnemonic here can help you to remember the names of the heart sounds. Now you are really inching your stethoscope from the aortic area to the pulmonic area. Erbs, S1 and S2 are equal in sound, tricuspid and mitral. So you're making this kind of a rough Z-like pattern. And then once you get all the way down, you've used your diaphragm, you're going to switch over to the bell or put the pressure for the bell, and you're going to go back. Some people like to start back on top, aortic, pulmonic, erbs, tricuspid, mitral. I usually start from mitral, tricuspid, erbs, pulmonic, and aortic area. Whatever you want to do, but you always have to kind of go in sequence, and you always have to start with the diaphragm first, right? You're trying to listen to normal heart sounds before you listen for murmurs and extra heart sounds. Don't limit your auscultation to these 5 areas. Okay, remember the sounds are produced by the valves, but they're heard over the precordium. So you want to use the areas to guide you. Now that we've had a little bit more context, I want you to go back and look at this slide again. And this is going to help you with the next question, particularly this area up here. So the next question is when you listen to heart sounds, you know that the valve closures can be heard best at the base of the heart. Which valve closures? So first you have to ask yourselves, are you looking at the base, which is the top of the heart, or the apex, which is the bottom of the heart, right? Or the lower, pointier side. So where are these valves located? When you are listening at the base, you're listening on top. And so that means you're at the aortic and the pulmonic valve areas. So be careful that you don't get the base and the top mixed up, or you're going to get the valves mixed up. That second heart sound, that S2, is going to be heard loudest at the base. This is the aortic and the pulmonic valves, right? And this tells you that we're at the end of systole. Loudest at the base. Now, in looking at extra heart sounds, we have S3s and S4s. We have summation gallops. I'm not going to be testing you on all these, but I did put them here in case you really want to geek out on it right now, or cardiac is your jam. Otherwise, as your nursing program unfolds, you're going to get more information of these things. Right now, I want you to be able to just signify, is it abnormal? Is it not a lub and a dub? And if it isn't, probably a murmur if you hear a gentle blowing, swishing sound, okay? A gentle blowing, swishing sound at the chest wall, this is a murmur. I want you to know that for the exam. And depending on when you hear it loudest at systole or at diastole, this is going to be a systolic murmur or a diastolic murmur. Innocent systolic murmurs between an S1 and S2 sound, so lub, dub, dub. Usually you hear this in children. Even here it says up to 30 years old. Sometimes I hear it in my 40-year-old patients, and it doesn't mean that there's a heart deficit or deficiency. It's in the term here, it's innocent. It's not medically significant. Once you identify a murmur, though, and you've identified it again with what part of the stethoscope, the bell of the stethoscope, you need to grade it. If it's very faint and hardly noticeable, that's a grade 1 murmur. If it's soft, it's a grade 2 murmur. If it's loud, moderately, it's a 3. And if it's loud, but you also feel, remember, that palpable vibration and there's a thrill, then that's a grade 4 murmur. If you barely have to put your stethoscope on it, that's a grade 5. And if your stethoscope isn't even on it and you can palpate the thrill and you can hear the murmur, that's a grade 6. That's a pretty intense murmur. You do need to know the murmur grading for the exam. So let's summarize. You check the neck vessels, you check the carotid pulses by inspecting and palpating, you observed jugular vein pulsation, and you estimated whether there was jugular venous pressure. And if it looked like it, you took your ruler out and you measured. Then at the precordium, you're inspecting and palpating the skin, and you're looking for the valve areas, right ventricular area to see if there's any heaves or lifts, and you're feeling for thrills over the valve areas. And you're trying to locate by inspection and also by palpation the apical impulse or the PMI. When you're listening, you're going to identify the anatomical areas. You're going to note the rate and rhythm of the heartbeat and listen for an S1 and an S2 and listen for the intensity. Where is S2 loudest? Where is S1 loudest? You're checking for any heart sounds by now moving on to the bell of your stethoscope and checking for any murmurs. Make sure you listen at the apex when the person is in left lateral position, because sometimes you don't hear it very well supine, so you want to move them over. And at the base, you want to listen at least once while they're sitting down. In lab, we're going to have you make sure the patient is supine during the cardiac assessment. So before we move on, I know you haven't had this part in pathophysiology yet, talking about heart failure or in your med surg class, but I do want you to understand more about heart failure so that you can understand the signs and symptoms. When we say jugular vein distension, it's because the pressure is moving up through those vessels, right? You can see all the different signs and symptoms that are associated to heart failure. And this is going to help you answer some questions about jugular vein distension, answer some questions about dyspnea and dyspnea on exertion, and orthopnea. You might also realize that because of the congestion of fluid, that you might hear some crackles and wheezes. And these are sounds, we call them adventitious sounds. These are abnormal sounds that occur when there's there's fluid in the lungs. You are going to learn more about this next week when we talk about the respiratory system. But please take some time to look at the pathophysiology of the heart, which will help you answer some questions on the exam. For our sample charting, you have it here. And for someone that is relatively normal, you would say that there's no chest pain, dyspnea, orthopnea, cough, fatigue, or edema. Remember, this is subjective, so you're asking these questions. This patient doesn't have a history of hypertension, no abnormal tests, no heart murmur or rheumatic fever. Had an echocardiogram 2 years prior to arrival, and the results were normal. So there was no stress echocardiogram or other heart tests that were obtained. This patient does have a family history of obesity, smoking, and hypertension, and was treated with diuretic medication. So this means that dad actually has the history here. Dad had to have medications to help remove the extra fluid from his body. So that's what a diuretic is. So he is a very high risk. This patient here is a very high risk of cardiovascular disease because it runs in his family. Other than his family, though, there are no other significant reports. Personally, our patient here has a balanced diet, eats all food groups, has coffee, doesn't smoke, 1 to 2 beers occasionally on the weekend, does exercise, and is not taking any medications. So now the objective charting. So this is after you've done the physical exam. You will note that the carotids are 2+. So remember, pulsations, you grade them. 2+ is normal, and it's equal bilaterally. Internal jugular vein pulsations are present when the patient is supine, but they disappear when elevated to a 45-degree position. So you notice that they didn't measure because there was no elevation or distension. Inspection of the precordium shows no visible pulsations, no heaves or lifts. When you palpate, you do note the apical impulse in the 5th intercostal space at the left midclavicular line, and there's no thrills present. When you auscultated, you noted that the heart is beating at 68 beats per minute, regular rhythm, and you hear S1 and S2 normally. It's not diminished or accentuated. You don't hear any extra heart sounds and no murmurs. So this is a healthy patient. And this sample charting will help you with your lab charting in the future.